You're welcome back from that quick timeout. It's still Daybreak here on Trust Television, and it's time for us to dive into our discussion segment this morning. Now, today we're going to be talking about HIV and AIDS. December 1st was World AIDS Day, and we'll be having a conversation on that today. We're talking about tackling HIV and AIDS. We'll be giving an analysis on challenges, awareness gaps, and treatments following the recent World AIDS Day 2024 celebration themed Leave No One Behind. And we'll be looking at Nigeria's progress. Now, there was a recent report talking about, 72,000 new infections annually. We have 1.9 million people living with HIV in Nigeria and 53,000 AIDS-related deaths till now, and 34% treatment coverage for pregnant women living with HIV. Now, we'll be having our conversation around all of this, but joining us in the studio to talk about this, we have Dr. Miriam Ezekwe, Deputy Director and Head of Policy and Advocacy Division at the National Agency for the Control of AIDS, NACA, and a renowned pediatrician, public health expert, and health system strengthening specialist. Thank you so much for joining us, ma'am.
Thank you.
It's good to have you with us.
Same here. I'm glad to be here. Good morning, audience.
Good morning.
All right. Talking about World AIDS Day, seeing the numbers, it's quite alarming. Why do we still have this kind of numbers in Nigeria today?
Well, the numbers are much. On the other side, they are also not too much, because if you look at our prevalence rate, it's 1.4%. So the reason why it appears on the higher side is because the population. Nigeria population is about 218 million today, and so that now gives us about between 1.9 to 2 million persons who have HIV in Nigeria. However, it's not all gloom. Because of these numbers, we have 1.6 million persons already on treatment. And as you know, treatment is free and it's a lifesaver. No one has to die anymore because of HIV. In fact, the major challenge that we even have right now is with regards to children. That's the pediatric age group. Because by the data, the most recent data that we have, both locally and internationally, about 160,000 children are born with HIV annually in the country. And that tracks to the women, because it's the women that give birth to the children. So we are really putting a lot of efforts right now in getting to women wherever they are, wherever they deliver, pregnant women, to have their HIV test done as part of antenatal care. So, and HIV is not in a vacuum. It has social constructs. It has the determinants that affect it. So we are working most seriously with a lot of partners, both line ministries in the country, international partners, to reach everyone wherever they are.
All right, Doctor, give us a sense of, you said it's not all gloom. Give us a sense of how much progress you think we have made with the data that are available to you, because once upon a time in this country, it felt like the moment you're pronounced to have this disease, it's just come down to, in fact, for some persons, anxiety will kill them before the disease. But somehow the conversation has completely disappeared from our streets. We don't see those kind of images that were coming out of our hospitals from lack of care and all of that. How much of progress do you think we have made, especially in the last decade or two, with regards to arresting this situation?
Thank you very much for that question. We've made a lot of progress. HIV, our first cases were 2 cases actually that were reported internationally, were in 1986. It actually occurred in 1985, but we reported in 1986. And at that time, we had prevalence rates even as high as 5.6% at a particular time. But now it's dropped to 1.4%, so that's a progress. There was a time also where less than 50% were on treatment. In fact, that was what even led to the birth of the National Agency for the Control of AIDS, which started as an action committee, so that we can move from an emergency to a treatable condition. So right now, our progress is towards ensuring that 95% of persons know their status, 95%, and that means 95% must get tested first. And then 95% know their status, and then 95% of those who are positive are virally suppressed. That means being on treatment. So for us as a country, we've done very well on this 95, 95, 95. Where we have a little challenge now is on those who are virally suppressed. We're already doing about 93% on the first 3 95s. It's only on the last 95 we're doing about 80-something%. You know, why I'm giving some variants, I mean some like not very precise, is because data keeps on changing every day.
Absolutely.
And the last data that we got as far as October, because we normally validate, showed that precisely 1,588,000 persons are on treatment. I'm just trying to tell you how particular we are. So we've made progress. There was a time when you only had to go to a teaching hospital to get treatment. Now you can get treatment even as lower down as primary healthcare facilities. So that's progress. Then we also have the psychological care, because you spoke very wisely too about how people used to die from just the anxiety. But now we have support groups. We have persons living with HIV in support groups. We have networks of persons living with HIV, NEP1, who are very strong, and they are even partners now, because there has been a slogan for a couple of years that says, nothing for us without us. So you find that even those who have HIV are now at the forefront managing the program. So I would say that we've made a lot of progress, and less people are dying from HIV than before. In fact, our plan now is to ensure that HIV stops being a disease of public health importance by the year 2030. And Nigeria is not going to be left behind.
Interesting.
Which is why we are focusing so much on the children, because that's where we have more of the challenge.
All right, now let's talk about awareness gap and stigma reduction. You spoke about, wanting to reach out to women, and is it safe to say that the number of women who are, having these children are located more in the rural area? Because I could attest that during my antenatal, I did HIV tests twice. For the 2 times I attended antenatal, we were forced to. You do it, you bring your husband, and the both of you will do HIV tests, everybody that were there. But what is the level of awareness when it comes to pushing this to women in the rural area? And how are they being educated, especially when it comes to stigma, their stigma reduction and awareness for people in the rural areas?
Okay, thank you. I mentioned at the beginning about the social construct that we are in. Because you've touched on a very important issue, which is on gender. Because the way health issues, many issues are viewed, has to be viewed through the prism of gender. Now, the pregnant women, and the cultural background too, there are some cultures in the country where women cannot access care except with the permission of a senior male member in the family. Could be the father, could be the brother, could be the husband. So we've done a lot of programs in reaching out to the men, what we call male involvement. But there's a little challenge with the men. One of our panelists here can attest to the fact that men don't go to health facilities. Normally, they have to be taken.
They're busy making money.
They don't go, but they have to be taken. So based on that, we found out that we have built up so much on mentor mothers who are able to go into the homes and speak to those women where they are, giving them access to those women. And these mentor mothers are usually women who are HIV positive, respected in the community, who can go and talk to the women who are pregnant wherever they are. And they don't have the barriers which could happen as in if it was a male. Then, on the issue of awareness again, we've done a lot of work on the social media too. We've done a lot of work with community actors, gatekeepers, because communication I'm talking with communication experts, can be horizontal as well as vertical. So we found out that, you know, a lot of what we used to do in the past, which was necessary, was really vertical. But now we are doing a lot of person to person, you know, skits, programs, and just recently, in fact, as recent as yesterday, we just unveiled our Goodwill Ambassador for HIV in the person of Mrs. Funke Akindele of Jennifer fame. So she's promised to also work and reach out to audiences that ordinarily we are not able to reach out to. And you spoke of something very important, stigma and discrimination. We're also working very closely with the health workers, because a lot of HIV positive individuals, you know, fear going to health facilities out of fear of maybe the confidentiality will not be there,
compromised,
the stigma, and even the knowledge that the health caregivers give them, what we call health literacy, may be affected by a person feeling self-stigmatized. So we are doing a lot of work in this area. We're also doing a lot of work in groups that we call the key population, because every population has the drivers. And we found out that the drivers for HIV in our communities are sex workers, both males and females. Like I told you, gender, you have both men now and females doing sex work. Men who have sex with men, persons who inject drugs, even persons in custodial settings. We reach out to all these groups. So a lot of work is being done to those persons who are the drivers of the epidemic. And I believe that stigma and discrimination will be going down. Programs to attract the women into care, delivery, working with traditional birth attendants. We've been doing a lot of that because we found that a lot of, let me not say a lot, but a good percentage of women will deliver with traditional birth attendant. So why not go meet them wherever they are? So we have trained those traditional birth attendants on how to administer HIV tests. Because even now, even for those who don't feel that they can be bold to go to health facilities, there are HIV self-test kits, which can be bought from any pharmacy, and you test. And once you test, you can now go to the health facility for you now to be tested again and enrolled into care, just to be sure. But at least it screens up those who are not sure of their status. And you know, once you're tested, it makes you, so having a negative result doesn't mean, oh, great.
You're not free to go back to
No. It just means that you should take more care and take up other prevention methods. You know, in the past, we talked a lot about ABC. Now, it's even gotten up to D, because we talk about abstinence, because your message has to be audience specific. We're thinking about the adolescents and the youths. Abstinence, there is be faithful to your partner. And then C is to use a condom. And even the abstinence even has an abstinence plus. That means when you cannot abstain, the plus part is the condom. And then the D is don't do drugs. Because when persons are under the influence of drugs, you can't make the most rational decision in terms of risky behavior, and even in terms of sharing needles, because HIV can be transmitted via the vertical method, that is from mother to child, and through heterosexual sex, through sharing of sharp objects. So we've really done a lot of work.
All right, Doctor, two other areas I would like you to provide a bit more enlightenment around, and we see a lot of those questions quite often. One is, how much progress have we made in terms of numbers with regards to mother-to-child prevention of transmission? Because I know with some of the early people who got into the programs who are sexually active and are in marriages, this has helped to curtail the number of kids they have becoming infected. That's one. There are also concerns, or rather little understanding around what needs to be done. Supposing, let's say, a partner has it, If the partner it's on the drugs and the viral loads are down, does it pose a health risk to the partner who is negative, for instance? What can they do to continue to sustain that the results, and keep everybody safe?
All right, thank you very much. Because you've gone into the area where we call discordant couples. That is where couples who are, one is positive and the other one is negative, and they decide to get married. I would like to share with the Nigerians watching the show, and in fact people around the world, that's one of the wins, the gains, and that is wins of the HIV program in the country, whereby once a HIV positive individual has undetectable viral load levels, it means that the person cannot transmit HIV to another person, to an intimate partner, to an unborn child.
Really?
So that's why it's so important that whoever is HIV positive should be on treatment. Because there was a time when we were pushing it a lot. About a couple of years ago, U equals to U, meaning undetectable is equal to untransmissible. And then looking again at women particularly, because they are the ones that birth the next generation, we have programs for primary prevention, meaning for women don't even have HIV, by using these measures I mentioned before, the A, B, C, D. Then when a woman first learns that she's pregnant, we always advise, even without HIV, to start antenatal care in the first trimester of pregnancy, which is the first 3 months, whereby you're now put on life-saving ARTs that would cover the pregnant woman, and then instituting methods that ensure that the baby is born without HIV. Anyone that is trained in this will know what to do. And that involves giving nevirapine, which is one of the drugs, to the newborn baby within the first 72 hours. Then testing that baby until the baby is, within the first 18 months, to ensure that the baby is free or HIV negative by that time. So we've had so many cases. I think the main important thing is the information to reach people out there, that even if you're HIV positive, you can marry a HIV negative individual, whether man or woman. And if the woman is HIV positive, she can deliver a HIV negative child, because our aim is to have a HIV
free generation,
HIV negative generation, or HIV free generation, or we call it Generation N or Gen N, meaning HIV negative generation. So in fact, in FCT, we have a lot of programs all over the country. But to push this further, we recently launched, in partnership with the Federal Ministry of Health, led by the Minister of State for Health, the PMTCT, that's Prevention of Mother-to-Child Transmission, as well as Pediatric ART, as Antiretroviral Treatment Acceleration Program. This has been already launched in 3 states, and is going to go around the whole of the country. That is 36 states plus FCT. And so far, in all the states we've launched it, the governors have participated, because we want to see how we can use the structures we already have to maintain. Because one of the challenges of projects is that project comes, it ends. What about sustainability? So we are now talking about sustainability in the country, and it has really gone very far, with support of our funders, support of other partners in the country, and the use of the normal structures, whether the primary health care, secondary or tertiary health facilities, as the teaching hospitals, in order for us to sustain what we have. And that means using whatever any institution has, whatever mandate you have. For example, NACA has the mandate to conduct multi-sectoral coordination in Nigeria. And that means the health sector, that means women and youths, sports, housing, whatever sector, education, because a lot of our youths are in education. So we've been reaching out and getting everyone to see how we can continue to propound the sustainability ideology to everyone, because I mean everyone knows that funding is reducing. Now we're talking about efficiency. So let's use whatever we have as efficiently as possible.
All right, you spoke about pediatrics. Now let's throw it down to the children a bit. I love how you mentioned the initial care that could be given at birth by administering the first drug 72 hours and then running several tests. Now that we have this number of children, what care is necessary for them at this point, the number of children who are positively infected, what care is necessary that, you know, could be administered to them, and, you know, what precautionary method could parents at home take and also health centers take towards protecting and, you know, taking care of these children?
Okay, thank you. Firstly, you know, care, we can look at care from the medical point of view, social, education, psychosocial as well. Because there was a point that one used to make before, that just knowing children are also human beings. So the first thing is, at the point of delivery, the mother or the parents owe it a responsibility to ensure that that child is born HIV free. That means going through the gamut of what is called prevention of mother to child transmission program. Now, when that child is born and that program is done successfully, that child should come out HIV negative and live the rest of his life like any other person. Now, on the other hand, assuming maybe the mother did not have a successful PMTCT program, maybe due to presenting late, because you have some women who don't even attend antenatal at all. It's at the point of delivery that you may see them in hospital for delivery, or sometimes they don't even come. It's at the point when the child comes down with, you know, illnesses, and then you now do a screening. So what we do is that once we have that child, we do what we call SNU, that is the testing of the family to know where it's coming from. So we now see the family as a unit and offer them psychosocial care, counseling and all. Then for that particular child, the child will now be placed on ART, because there are pediatric ART drugs, which the child will now be on for life. And if that child takes the ART drugs consistently, then the child would live like any other child in his class or in her class. Then the challenge sometimes has to be with ingesting of drugs. The good thing now is that ART drugs, you know, in the beginning, ART drugs were like a little bag that you take every day. But now it's dropped to just one pill a day.
So compliance is
compliance
increased.
is high. So that child can take it under the care of the
just
parents.
like a supplement.
Yes. Now, that child should also have counseling with the parents. The parents should know the right time to tell that child what exactly he or she has. Because some parents, out of love, you want to protect the child, you don't tell the child. So it's very important that the child gets to know. And if parents feel that they don't have the ability to do it, then a specialist or a specialized healthcare professional could come and support the family to inform the child what the child has. And this is a very important thing, because if it's not handled well, that child could become reactive and start to act out. So it's a very, very important stage. And that child should now be told, you're not going to be alone for life. You can also get married, have your own children, and live like any other person. So it's very, very important to know this.
Doctor, I've been giving you questions in twos. Two areas that are also very important to me. One, we live in a society that sometimes, for reasons we can't explain, we just fall out of compliance. And I'm saying this with regards to your opening statement around how you have succeeded in decentralizing help and support or care to even as little as primary healthcare centers. What amount of oversight do you have in these places? Because today you show up even with your NHIS or whatever health management platform you're subscribed to. You show up at these hospitals, you manage to see a doctor, and when you get to the dispensary, they will tell you no drugs. You have to go and buy over the counter, or you have to give somebody money to get you what they should as part of your health package. How much of oversight is happening to ensure that there are availability that we do not compromise the outcome by those kind of practices we see, especially in far-flung areas where there are very little supervision? That's one part of the question. The second part is when you spoke to sustainability. As an agency, charged with supervision and the overall management of this situation, how much are we doing as a country to start domesticating the production of these ARTs such that we would not be at the mercy of international? I mean, we saw what happened with COVID with as little as malaria drugs that some countries had to stop the experts to be sure that they have sufficient for national consumption and all that. What can you say to this too?
Okay, thank you very much. We have the first question you asked is with respect to the
oversight.
Oversight, thank you. So, oversight, like I said, NACA, we don't work alone. We are a multi-sectoral coordinator. So, you find that in fact, your question is even linked to the second question, sustainability. You have government agencies that have been mandated to oversight at different levels. For example, you will have at the state level, you have the hospital management board that oversights staff recruitment, discipline, and all. Then you also have the central medical stores with their systems, which include their logistics group in the ministry to ensure that drugs are there. Now, for Nigeria, we are blessed in the sense that with particular to ARV drugs, there's a unified procurement system and a unified system of ensuring that everyone puts their funding into that one pool to procure drugs, to procure RTKs as the test kits, and then other HIV commodities. So I would be glad to tell everyone that we've not suffered stockout for many years. Because we also have what is called the last mile logistics that ensures that drugs get to the last point. And we even have different modes of persons picking up their drugs. So everyone gets prepared. There are those that pick up their drugs on a monthly basis, especially when they are starting out, and those who, when they are stable and on their drugs, their tests are okay, they don't have any health challenges, they could pick up their drugs every 6 months.
Okay.
So it's as fast, so that there's not that pressure on the health system. So that's what we call the differentiated service delivery model. So every person has a delivery model that is tailored to his or her need. That is it. Then in terms of the sustainability, we are already working to have production of key pharmaceutical ingredients in country. That is a plus on the side of agency from doing lots of advocacy, so that we can now start, because you have countries like South Africa where they're already producing generic ARVs. So we are already on that track now by having the production of key pharmaceutical ingredients in Nigeria. And we're also working towards production of other HIV commodities like condoms, as well as test kits in the country.
All right.
Okay, it's been a wonderful conversation with Dr. Miriam Ezekwe, the Deputy Director and Head of Policy and Advocacy at NACA. She has spoken to a broad range of issues. We wish we had all the we could trap doctor within our systems and take all of our questions and possibly phone in, but time would not allow us. But I'm sure we have done justice to the little time we've had. She's spoken extensively on what you need to know, where you need to go, what you need to do, and how much effort the agency had put in making sure that as a country we work towards attaining the universal goal of a HIV-free nation by 2030, is it? 2030.
Yes.
Thank you very much.
Yeah. And I don't know if I could just say something.
Go ahead, please.
Thank you. Which is to say that we are standing on the right path. That's what this T-shirt says. You know, take the right path. That's why we are focusing on the kids. And then the second thing I would like to say is that we have a toll-free number at the agency, which is 6222. That is 6222. So if you have any questions, it's toll-free. Wherever you are in the country, you can call. Then somebody will talk to you and tell you what to do.
Okay.
Thank you, Dr. Miriam, for this wonderful enlightenment engagement that we have had in the studio. We would take a quick breather. When we return, it will be time for the stories that made it to the front page of select national newspaper. Please don't go away.